Hello, I'm Dr. Omar Bey, and we are the Physicians Health Network of OBHealthy. We're here each second Saturday to do two major things and two major purposes for the reason the physicians are here. Number one, we would like to let young African-American males and females, but mostly males, know that they can go into medicine, and that they can do it, and that they can become a doctor. If we really look at the statistics, young Black males are not going into medicine, and we want to change that fact. We want to let them know that they can become physicians and think about it. The second is that we want to educate from a medical standpoint everyone who's of Black descent or African descent. Education as far as medical care is concerned is so important for each and every one of us to do well medically and be healthy. All righty. Understand that we are here every second Saturday at 1 o'clock. You just have to go to obhealthy.com and sign on, and you can type in your medical questions. On the bridge, you will see Physicians Network, and just click that and follow. Hold on just for a second. And follow the instructions and sign on, okay? I also would, and the physicians are coming in now, so I'll give them a chance to come in. All righty, we have quite a few questions to talk about this time, and I think you will really enjoy this webinar. As far as our past webinars, you can go to OBHealthy and just scroll down and just go to the YouTube icon, click the YouTube icon, and all of our past OBHealthy webinars will come up. You can listen to all of them, all righty? And please do, and please tell family members, church members, friends about the webinar, as I stated, every second Saturday. I would like to also let you know that we have that there is an app, that's the OBHealthy app. And if you decide to download the app, there are approximately 80 health videos on that app that I feel that's geared for African Americans, number one. And there is weight loss, there is how to eat, so many good things for us to be healthy. Remember, if you download the app to your phone, please put in the code 365, and that will allow you to get the app for free. So 365, 365 days in a year, 365, get the app for free. All righty, let's get started. I would like to introduce and allow the physicians to introduce themselves. And we're going to start with Dr. James Court. Dr. Court, can you please introduce yourself?
Good afternoon, Dr. James Court. My practice is in East Orange, New Jersey. My specialty is internal medicine, and I practice with most of the members of the panel at Newark Israel Medical Center.
All righty, thank you. Dr. Kendall Sprott.
Yeah, I'm Kendall Sprott. I'm a retired pediatrician. I specialized in pediatric critical care and general pediatrics.
All right, thank you. Dr. Trevor Atherley.
Good afternoon. My name is Trevor Atherley. I'm an interventional cardiologist. My practice is predominantly at Newark Israel Medical Center.
All righty, thank you. Dr. Patrick Anderson. Patrick, you're still on mute.
Good afternoon, everyone. I'm Patrick Anderson. I'm a GYN oncologist. I take care of women reproductive cancer. As with many of the panelists, I practice out of Newark Israel Medical Center.
Thank you. Dr. Jordan Garrison.
Assalamu alaikum. My name is Jordan Garrison. I am a general bariatric and vascular surgeon, specializes in diseases of the veins. Practice in Hackensack, New Jersey.
All righty. And Dr. Kareem Salam. Welcome, Kareem.
Good afternoon, brothers. Good afternoon, everyone. My name is Dr. Kareem Latif Salam, board certified adult and child and adolescent psychiatrist, and I practice out of Philadelphia.
All righty. And we will have other doctors joining in. I know Dr. Clark is still in surgery. He states that he'll come in as soon as he's out of the OR. first thing I would like to say is, and this is the most important thing I think I could say during this whole webinar, is that, oh, we have another doctor calling in. Hold on just for a second. Just give me a moment. The most important thing that I can say is that please do not change any aspect of your medical care until you consult your physician. Only your doctor, and I must say that, only your doctor can truly treat you and make sure that your medical and your health is 100%. Only your doctor can do that. Please do not change any aspect of your medical care. Let's get started. I'd like to, there was a question about low thyroid, and the question was, I have low thyroid or hypothyroid, and what are some of the medical problems that I'm going to have because I have hypothyroid? And there's an opposite end of that. It's called hyperthyroid. So maybe we'll get this started and just talk open about it. From my perspective, and let me just give my perspective. Oh, there's Dr. Aluya. All righty. From my perspective, before we get started, let's introduce. Hold on. He lost his picture. And from my perspective, basically what we're talking about is weight and hypothyroid. Understand your thyroid is that area of the body that regulates how fast you or how rapid you burn calories. And if you eat a certain amount of calories per day, if you have hypothyroid, that means that at the cellular level, you're not burning up those calories. And if you don't burn up those calories, then what we do is we store those calories in fat cells. And that causes increased weight over time. So patients or people that have hypothyroid, low thyroid function, have to be very careful as far as what they eat and how they eat, and making sure that they exercise so that they burn off those extra calories so that over time they don't become overweight. Can anyone else chime in on this? Dr. Aluya, I see you just came in. Can you introduce yourself, Dr. Aluya? You're still on mute.
All right, great. Good afternoon, everybody. Sorry, I'm joining you late. I had to rush up between work and stuff. My name is Nelson Aluya. I'm a medical advocate, medicine and pediatrics trained. Always a pleasure to be in the presence of these great, esteemed colleagues, brothers, and it's a pleasure to be in your living rooms every second Saturday of the month, talking about health and health-related issues that concerns our community. I'm an attending physician at Noah Beth Israel Medical Center, and also an assistant professor at Rutgers University, New Jersey Medical School. Thank you.
All right, thank you. Dr. Sprock, you want to go after hypothyroid and hyperthyroid a little bit? We'll get started, and then
Sure.
I'd like Dr. Atherley to kind of talk to about from a cardiac aspect as well. Go ahead.
Yeah, so the thyroid gland is the gland that's in your throat area. And sometimes when people notice that there's growth or an enlargement in that area, they sometimes call that a goiter. And that may be part of what we were talking about, either hypo or hyperthyroidism. And as Omar, Dr. Bay said, the thyroid hormone is one hormone that's essentially responsible for what we call the metabolic rate. And so when we talk about metabolism, your body is constantly building and breaking down. And it's sort of an equilibrium or a balance is what's taking place. And so the thyroid hormone is responsible for what your metabolic rate happens to be. And as Dr. Bay said, you know, when you eat food and you eat calories, those calories can be lost in excreta in your gut, or sometimes spilled off in your urine if you have diabetes. But a lot of the calories are related to your activity. And so when you're up and around and you're exercising, you're burning calories. But even when you're asleep, there's a certain amount of calories that are being burned because of your metabolism. And for children, an important element of the calories that children take in are going towards their growth. Once you get to be an adult, hopefully you won't grow, you certainly won't grow any taller, but we hope that you don't grow any wider. But as he said, that if you have calories in excess of what you're burning up, then very often it gets stored as fat and you can become overweight or obese. And so if you have an alteration of your metabolic rate, and one of the things that can speed up your metabolic rate, if you will, is to a certain extent exercise. Another one is fever. But the thyroid hormone is really the thing that is responsible for speeding up your metabolism. And if you have an increase in the production of your thyroid hormone, and again, that can occur because your brain sort of regulates the amount. It keeps it in sort of balance. But if your thyroid hormone goes up, then your metabolic rate will speed up and you will start to burn more calories. And if you're eating sort of the same amount of calories on a daily basis, you start to burn those calories, you will start to lose weight. Despite the fact that you may be eating the same or be eating more, you will lose weight. If you're hypothyroid, that means that your thyroid hormone isn't producing enough of that, the thyroid gland isn't producing enough of your thyroid hormone, then the reverse will happen. You know, some people, when they're overweight, they say, well, maybe I have a problem with my thyroid. That's sometimes the case, but rarely is that the case. And so if there is an issue where your thyroid hormone is low, you may have weight gain. You also may be fatigued and you may not feel just up to snuff. And one of the things that people will do in terms of evaluating people if they are overweight is to do a thyroid hormone. Or if you have a rapid weight loss, they'll do a thyroid hormone level. And one of the things that they'll do is they'll look at the part of the brain that's pituitary gland that releases something that stimulates the release of the thyroid hormone, or if your thyroid hormone is low, then that level goes up trying to get you to make up more. And sometimes that increase in the release of the thing that stimulates the thyroid causes the gland to grow. And so if you have a growth in your throat area, right where we talk about the Adam's apple is, that's an indication that there may be an increase in the stimulation of the thyroid gland by the pituitary. But as we said, thyroid hormone is critical for your overall metabolism. And if it's out of balance, then you're going to have either weight gain, and sometimes you might have hypertension, you might have jitteriness if it's elevated, the opposite if you slow down, if you have hypothyroidism.
Dr. Atherley, I know that thyroid and the heart is definitely related. Can you tell us how you evaluate the thyroid when you have a heart condition?
Well, every now and again, actually, we diagnose thyroid disease as a consequence of the presentation or the effect that it may have on the heart. Now, hyper and hypothyroidism may both affect the heart, perhaps in opposite ways. When one has hyperthyroidism, an excess of the thyroid hormone, and it generally increases the metabolism of the body, it may have effects to increase some of the function of the heart, such that simple functions as the heart rate may be recognized to be increased. Normal heart rate is usually between 60 and 100. And when we see patients who have heart rates higher than that, we are often tempted to check to be sure that the thyroid is functioning adequately and that that is not the sole or the initial presentation of hyperthyroidism or excess thyroidism. So a speeding up of the normal heart rate is one of the findings that we have with hyperthyroidism. What we can also find is not merely an increase of the normal rate, but an abnormal rhythm. Atrial fibrillation is considered nowadays to be the commonest sustained or continued arrhythmia, irregularity in adults. And one of the causes of this is hyperthyroidism. And what we do diagnose, how we do diagnose this is not only by the irregularity of the rhythm, but we do have on electrocardiograms, you see, we can measure actually the atrial or the function of those small pumping chambers in the heart called the atrium. And we can document that they themselves are the source of the problem. They're beating erratically and irregularly and causing other chambers to follow suit and beat faster. So hyperthyroidism may commonly be associated with the speeding up of the normal heart rate or the presentation of an abnormal heart rate and rhythm called atrial fibrillation. What's important is that while we normally can treat atrial fibrillation in specific ways with some medications or other interventions, however, if the underlying cause is hyperthyroidism, it is important that we control the hyperthyroidism or we will not be able to easily treat the atrial fibrillation. So when that presents with hyperthyroidism and atrial fibrillation, then we must control the thyroid function. And after that, we can hope to get better control of the atrial fibrillation. Now, the opposite may happen when hypothyroidism exists. Here we see hearts that are beating slowly. We have bradycardias, and a bradycardia means a slow heart rate. They mention that the heart rate generally is between 60 and 100. So in slow heart rates, one of the things we may suspect is hypothyroidism or diminution of the amount of thyroid hormone that is actively circulating. In addition to that, we also have some structural abnormalities. When patients have severe hypothyroidism, fluid may accumulate in certain parts of the body. The lower extremities, yes, but the one that we may be concerned about is fluid around the heart. We may have myxedema pericardial effusion, and that is fluid surrounding the heart, outside the heart, which in the case of hypothyroidism usually does not cause a major problem. But there are times when fluid outside the heart can so squeeze the heart and constrict it that the heart may be unable to function in a normal manner. So it is important that we diagnose, we look at the size of the heart on chest x-rays, and we also do EKGs in patients who have hypothyroidism, just to be sure that there's no pericardial effusion. So those are some of the manifestations that we sometimes see and have to deal with as cardiologists in thyroid disease.
Right. Next, Dr. Garrison. I know that Dr. Garrison had raised his finger. Please expand on it.
You know, I think everybody's done a wonderful job to talk about the effects of hypo and hyperthyroidism. But what are the causes? The most common cause of hypothyroid or decreased thyroid hormone is a disease called Hashimoto's thyroiditis. And what it is, it's a viral entity that attacks the thyroid and it basically poisons the thyroid. And so it stops producing thyroid hormone. This is self-limited. It does not require surgery, and there are no medications that really need to be given other than to support the thyroid until the viral infection subsides. The other causes of hypothyroidism are iodine. In countries in which the iodine or the salt is not iodinized, I know that's a political push button for a lot of people about whether or not we should be iodizing the water, fluoridating water, iodizing our salt. But if you have a decreased iodine level, you can get what Dr. Sprout was talking about, a goiter, which is an enlargement of the thyroid. The treatment of that is to continue to give iodine or supplemental iodine to the person. The third most common cause of it, as Dr. Sprout again talked about, was an adenoma or a growth in the pituitary gland. And this growth can cause either the thyroid to produce or to decrease the amount of production of the thyroid. On the other side is hyperthyroidism, or too much thyroid hormone. And that can be caused by something called Graves' disease. It was discovered in the 1800s, and basically your body starts producing factors in an autoimmune fashion in which it recognizes your own thyroid as a foreign material. And therefore it goes about trying to destroy or stimulating the cells to produce more thyroid hormones. Again, this is not a surgical problem. It is something that can be treated with supportive measures and some thyroid supplements to decrease the amount of stimulation to the thyroid.
Question for Dr. Athley.
All right, Omar.
Hold on. I know Dr. Salam was going to be next, and then we'll continue. Dr. Salam, please.
Yes, thank you very much. Some of the psychological consequences of hypo or low thyroid function are poor memory and concentration, flagging energy, could also have an effect on mood and could actually look like depression. Hypothyroidism, its presentation could be so similar to depression you actually want to rule that out in anyone you suspect has clinical depression. So if someone has normal thyroid function, but they present clinically depressed, then perhaps they are clinically depressed. But you certainly want to rule out hypothyroidism in someone who's depressed and you're admitting them to the hospital. There are certain medical conditions that could mimic psychiatric ones. The challenge with the medical conditions is that they could do you more harm more quickly than the psychiatric condition. So you really want to make sure you exclude those before you diagnose someone with a psychiatric condition. You don't want to miss a medical process that could do them significant harm. Another consideration with hypothyroidism, a common cause in the psychiatric community of hypothyroidism is exposure to lithium. So lithium is a mood stabilizer. It's one of the primary mood stabilizers. It's been around for decades. It's a very effective medication used to treat bipolar disorder, formerly known as manic depressive illness. But one of the side effects of lithium use over an extended period is hypothyroidism. So for example, I treat a number of youngsters with bipolar disorder, but lithium is not my first choice of mood stabilizer for children and adolescents for that very reason. Now, I have treated youngsters with lithium after having tried them on second and third line mood stabilizers. So that's certainly a consideration in someone who is prescribed lithium. Finally, when you are prescribing medication for the brains of other people's children, unlike adults, you think in terms of first doing no harm versus prescribing them the medication that's most effective. The thinking is a youngster who's on psychotropic medication, there's a chance that they could be on medication for a long time. So you would like to expose their developing brains to the fewest and least harsh side effects over time. And so if someone has bipolar disorder and they've not responded appropriately to non-lithium medications, then you would arrive at a course of lithium after they have not done as well on less harsh medications.
Excellent, excellent. Dr. Patrick Anderson.
Yeah, so to the panel and the audience, it's interesting how this one gland can integrate all the subspecialties in medicine. In women's health, one of the most important things a doctor can do is to do a comprehensive history and physical. And how the thyroid is integrated in women's health, one of the most common indication that something is going on with the thyroid is menstrual irregularities. Now, remember the thyroid glands through its stimulant TSH cause the production of T4, which is actually inactive, but the active form needs to occur through transformation, either the gut, the kidney, or the liver. Now, if you cannot convert T4 to T3, then you become hypothyroid. Hypothyroidism, we know, causes menstrual irregularities. So to the primary care physicians or to the gynecologist who has a patient at any age who complains of menstrual irregularity, one of the evaluation is evaluate the thyroid. As you know, the thyroid affects mood, energy, menstrual irregularity, menstrual cycle, ovulation, and appetite. So when you interview a patient and they give you all those symptoms, one of the things that comes to mind is how well is the thyroid functioning?
All right. I think
Question for Dr. Atherley.
all right. I think Dr. Anderson, your connection is, we lost your connection, but continue.
Yes.
We lost your connection.
Hopefully it'll come back. So most of the irregularities we see in women's menstrual cycle is related to hypothyroidism. However, if patient comes into the office and she's tachycardic, the heart rate is fast, she's losing a lot of weight, sweating a lot, she could have reproductive condition that's related to hyperthyroidism, overactive thyroid, but indirectly. So there are tumors in the ovaries that makes thyroid hormones. These tumors are called struma ovarii. So whenever anyone sees any patients who have these conditions, even Dr. Salam, I can tell you when he sees what's the importance of a vital, or Dr. Athley sees a patient who's tachycardic and he gets an EKG and he sees sinus tachycardia, then what's going on? Thyroid hormone producing ovarian tumors, which can make the heart beat fast, causes weight loss, night sweat, inability to sleep, and so on.
Righty. Yeah, thank you. Thank you very much. Dr. Aluya, I know you're internal medicine. Do you have anything to add?
Yes, internal medicine and pediatrics. A few things. I mean, you guys basically just talked a whole lot about it and extensively as well. Other medications, in terms of medications, especially medications that are used to treat heart arrhythmias, like amiodarone itself, can cause either hypo or hyper. And we've had a number of cases of individuals who have gone through chemotherapy for cancer treatment. Eventually, they do come down with hypothyroidism as well. Before I diverse into the pediatric aspect of it, the thyroid, like Dr. Anderson had just said, is one small, very small organ that affects the whole body completely. And as it does this function, it's also prone to cancers as well. And one of the things that we have come to see often enough that, people tend to forget that the thyroid cancers can come from there. And they're very small, they're very hidden. And if you're not careful, you tend to miss them. And people don't present a whole lot of the times with symptoms, except a few cases where they say hoarseness of the voice or a few things like that. And a lot of them are actually found incidentally when you do other scans for other medical conditions. So to the audience, it's something to be cautious about. If you examine yourself or you feel abnormal mass, or you see that the neck it's unequal and one growth here or the other, you have to seek your doctor and have it checked properly. First with an ultrasound, and of course eventually a CT scan, and if need be, get a biopsy to take a typical look of the tissue and see what if it's just regular thyroid, or if it's just a goiter, or if it's an infection, or even if it's cancer. There are 4 types. I think there's the medullary, the papillary, the anaplastic, and the follicular. And these occur in different stages and different times and different age groups. So I won't go into that. But coming back to the fact that the thyroid hormone controls a whole lot of things. As a pediatrician, I've seen cases not that common here in the United States anymore, but in developing countries. And of course, the US is a home to a lot of immigrant community and immigrant families. So, and Dr. Anderson will know that the thyroid that the child develops, the function of the thyroid hormone in the baby in the uterus comes from the mother, not necessarily because the child has not had the capacity to produce his or her own already. So by the time the child is born, there's some process that takes on and kicks into process, and then begins to produce its own. However, if there's a failure, complete failure of that kickstart for the baby, for it to produce its own, the thyroid is responsible for the growth of the bones of the face. Is also involved in the development of the neurons in the brain. And that's why in those kids, like I said, we don't see them that much. They're called cretinism. The babies are usually small, tiny, and then they tend to have small face, and they tend to have mental retardation as well. But the beauty of this is this: once you identify that and you put them on medications, they do very well and they recover really fast. And that's why here in the United States, as well as the other metabolic things that we screen for, Maples disease, sickle cell, they also screen for thyroid hormone. And that's why those things are cut off really early here in the United States. And kids who don't have them, they put on medications and they are treated.
What about, I'm sorry, Dr. Court, was that you?
Yes, I just have a question for Dr. Atherley.
Surely.
Okay, a patient comes to me and I tell them, you have something is wrong with your thyroid. And Dr. Atherley tell me what section of the heart would be affected to trigger that patient to be bradycardic or hyper, or to have a rapid heartbeat or tachycardia. Does lack of the hormone or excess of the hormone affect a particular heart portion of the heart that causes the heart to beat slow or to beat fast?
Yes. Okay, good question. For what we do know, certainly the area of target with a significant elevation of thyroid activity, the area of target is the atria, and these atria fibrillate. The atria beat faster and irregularly, and in a most disorganized or dissynchronized way. The other area is speeding up the natural heartbeat. The beat for the heart is generated from what's called the sinus node. That's in the uppermost portion of the heart, a small area that electrically sends stimuli to all parts of the heart. So they go through the so-called electrical conduction system, affect the atria, the small chambers at the top of the heart, and go down to the bigger pumping chambers, the ventricles. Well, by stimulating the sinus node or diminishing some of the inhibition of heart rate of the sinus node, then these hormones from the thyroid may bring about an increase in the functioning rate of the sinus node. And then that is, of course, transmitted from the sinus node down through the atria and down through further conduction tissue to the ventricles. So what we find is that stimulation causes a speeding up of the entire heart. It may speed up in a synchronized way of the normal, allow the normal contractile pattern of the heart, or it may speed up certain areas, not just the sinus node, but the atria. And then they may beat in a disorganized way to cause what's called atrial fibrillation. So those may be the two target areas. Now, outside of the heart, one may get increased fluid formation. Now, we all have a little bit of lubricating fluid outside of the heart muscle. The heart's a muscular pump, and it functions within what's called the pericardium. That's a sac in which the heart fits. Now, there's always a small amount of lubricating fluid so that the heart can squeeze and move properly without jarring against the pericardium or the sac. In the setting of hypothyroidism, what can possibly happen is that the amount of fluid outside of the heart can become significantly increased, and that's called pericardial effusion. So there may be also that effect on the pericardium to cause greater secretion of this fluid. And in that case, it can affect the ability of the heart to function adequately in its filling properly with blood. So yes, there are several direct areas in which the thyroid hormone or the lack of thyroid hormone may impinge upon heart structure, function, and electrical activity.
Excellent. That was an excellent way to cover that topic. I think everyone chiming in. Excuse me?
Can I have one more thing that I'd like to add to that?
Sure. No, Dr. Garrison.
Piggyback on something Dr. Aluya was going down a path on when we talked about the types of thyroid cancers. First and foremost, thyroid cancers do not present hyper or hypothyroid. They're euthyroid or normal thyroid. So it shows the importance of a physical exam when a patient comes in the office to make sure that we do examine the neck for lymph nodes, examine the neck for enlargement of the thyroid. The second thing, and I'm going to ask Dr. Sprott something about this, one of the cancers, the papillary thyroid cancers, is really prevalent in people who have had prior radiation treatment to the neck. And this was done for children who had recurrent tonsillitis. I don't know if that's a treatment that's been done anymore. Dr. Sprott, what do you think? People still radiating neck for sore throats?
No.
or tonsillitis.
Well, when I was growing up, tonsillitis was a frequent diagnosis. And what we learned is that different tissue of the bodies have different patterns of growth. And so the tonsils are considered part of the lymphoid tissue, like lymph nodes. And what happens to the tonsils, which are in the nose and throat area, is that children are frequently exposed to upper respiratory tract infections. And the normal response to an upper respiratory tract infection is for those lymph nodes to enlarge, get bigger, to make the white cells to help to fight these viral infections. And what we found is that starting out at birth, the lymphoid tissue is very, very sparse. But as the child starts to grow and gets exposed to different types of viral infections, they enlarge. But around 11 or 12, they start to regress and shrink. And so people thought years ago, maybe 40, 50 years ago, that if they were enlarged, there was something wrong with them, and so take them out. And now that we realize that they're normally large in the first several years of life, and then they start to shrink as you get into the 11, 12 years of age. And some people that might have had big tonsils, by the time they're a teenager, you can't even find the tonsils. And so not only do we not do surgery very, very often anymore for tonsillitis, they may do tonsillectomies if that one has a certain amount of enlargement that causes problems with sleep or breathing. They might remove them, but they don't do that type of, I'll say, irrational therapy of radiation to shrink the tonsils. Now, once again, you talk about radiation, with the atomic bomb explosion, there was a lot of radiation that caused a lot of different cancers. And so we always knew that there was an effect of radiation that might precipitate cancer. And we learned during the early days when leukemias were around in kids. Leukemia was a fatal diagnosis in the age when I was a resident. But we learned that you could treat it with different types of chemotherapy, but often the cells were protected from the chemotherapy that if they were in the brain, or if they're in the cerebral spinal fluid. And so when we first started to understand that in order to kill some of the leukemia cells that might be in the brain with radiation, we figured out that you could kill those cells with radiation. But then we found later on in life that those folks that had got radiation to kill the leukemia cells developed brain tumors because of the radiation. And over time, we were able to find out the lowest amount of radiation that could kill the leukemia cells without causing cancer, and that's what we do. But no, Jordan, no one does that anymore.
Okay, excellent. We have we have a couple questions that have come through, and let me highlight those just for a minute. The first question is, can you talk about weight loss, exercising, how many times a week, and what should I eat or drink before and after I gather exercise? One of the best exercises is walking. And believe it or not, you don't have to go jogging 10 miles. You don't have to go to the gym and lift weights and all of that. Just getting out walking is an excellent exercise, even if you're trying to lose weight. As long as you do it on a daily basis, I think that approximately a half an hour, 15 minutes, a half an hour, if you walk a mile or walk a half a mile, or if you're overweight and you're not able to walk that long distance, just start walking and do it to your tolerance. And long as you do it each day, it's important. As far as what should you eat prior to and after, number one, you should stay hydrated. So it's always important to make sure you drink water, especially if you're sweating while you're exercising. Also, you don't have to, you gorge yourself with carbohydrates or anything like that. At this particular time, just eat, basic meals. Make sure your meals are balanced. Also, there is the Eat One Half weight loss program that's on the app. And that is an excellent 15-step program that is put together for people of African descent. And so many people around the world are losing weight because of this particular program. It's free. Download the app and it'll give you some ideas as to how to approach weight loss in a way that you don't feel punished, number one. Number two, that you can eat your cultural foods and still be healthy with weight loss. And that's so important, because I understand that when you change what you eat and how you eat too drastically, usually those weight loss programs don't last. And people get discouraged, they get tired and say, you know, this isn't in my cultural, these aren't my cultural foods, they're alien, they're foreign to me. It usually doesn't last. So the program was developed so that you could eat your cultural foods and feel comfortable, not feeling punished, and lose weight appropriately, so for better health. Anyone have to add anything to add to that? Dr. Garrison, yes, please.
Coming from the world of bariatric surgery, first and foremost thing you need to know is that bariatric surgery should be the last thing that you look at. Weight loss surgery. It's when all other things have failed. Weight loss and appetite is a multifactorial problem. There is the psychiatric component, which Dr. Salam is sure is going to talk about in a little while. There is the nutritional component, and then there's the exercise component. The nutrition and the psychiatric component are closely linked together. The exercise component is separate and apart, in that the goal, first of all, weight loss, 90% of weight loss is what you put in. Only 10% is exercise. You know, in order to lose a half a pound, one must run 20 miles. So obviously that is not the easy solution. Weight loss surgery is not a get-rich-quick scheme either. And it has to be a combination of nutritional maintenance and a behavioral alteration. As far as exercise, the goal is you want to get your heart rate doubled for 20 minutes, 4 times a week. That's the recommendation. That's how much you should be able to do. That doesn't mean, that means 10 minutes of warm up, 20 minutes of a discipline in which gets that heart rate going, and then 10 minutes of cool down. That's all you really, really need to help maintain a healthy weight. The other parts, I would refer you to Dr. Bay, and he's got apps, he's got nutritional advice, he's got supplemental advice, but there is no get-rich-quick scheme to weight loss. It is something that has to be constant. It has to be a lifestyle alteration that you can continue. Fasting is not recommended for weight loss. Lent is not recommended for weight loss. New Year's is not recommended for weight loss. It's a multifactorial disease that needs to be addressed in that manner. That's all I got.
Anyone else want to chime in?
Yeah, I'd just like to say a little bit about what we're talking about, which is, I'll say, excess weight when someone is overweight. And there are some definitions, some apply and there's some exceptions, because certain people who are, I'll say, muscle bound, people who build muscle might be considered overweight, but they like the excess weight that they have because it's muscle. Most of the people that we talk about that we consider to be overweight are overweight because they have excess amount of fat. And as Jordan said earlier, when you eat calories, a certain amount of calories, if you don't burn up those calories, then those calories will be stored as fat. And the calories that end up getting converted into fat storage are going to be carbohydrates and fat. Protein you can't store. You can add excess, a certain amount of increase in protein, but people that exercise with these protein shakes, there's very little evidence that you accrete a whole lot of protein by having these protein shakes. The proteins that you take in are broken down, and usually they get excreted in the urine. But the fat excess is what really is the issue. And again, the normal reason that you have fat is for energy storage when you need it. Well, in the old days where people only ate good during the spring and summer, and they would starve a little bit during the fall and the winter, there would be a reason for you to have that fat. But now that most people have access to food, the types of foods that you eat become important, especially if you're drinking sodas, for example, that have a whole lot of sugar. And the same thing happens when you talk about what you might take for exercise. You know, Gatorade and some of these other things also, not only do they have electrolytes, salts, which you might lose through sweating, also has lots of sugar. And so one of the things that becomes critical, and Jordan said it, is you have to really look at how you go about modifying your diet. And by modifying your diet, you know, I'll just give you an example. If you weigh 280 pounds, you need to eat a certain number of calories in order to maintain your weight at 280 calories. If you take less than that, then you'll start to lose weight. And so the idea is to look at what your desired weight happens to be, and then create a diet that you can stay on forever that consists of the calories that will get you down to that weight. If you start to take that amount of calories, which will be a reduction of the number of calories that got you at 280 pounds, then you'll get there. And it will help if you exercise. But again, the major thing that you have to look at, how you go about modifying your diet in something that is sustainable. We talk about a balanced diet that has, you know, the essentially components of fats, carbohydrates, and protein, but you don't want to have excess amount of calories. And what you'll find is that most people who said that they're on these diets are taking in calories in excess of what they are burning, and therefore they're gaining weight. And when Dr. Jordan talked about bariatric surgery, most of those surgeries are designed to limit how many calories you take in. And so if you are taking in a whole bunch of calories, but then you have a surgery that only lets a certain number of calories or a certain amount of food get into your digestive tract, then you'll lose weight. And so the idea is not to have to resort to surgery, but just resort to a change in your dietary pattern. Eliminate the excess calories and eat healthy. Eliminate excess fats, especially in combination with carbohydrates. The combination of carbohydrates and fat is lethal. And so you need to be careful about how much you eat and what you eat and when you eat. If you're going to eat late at night when you're not going to be burning up, then that's just going to go to storage. And so you should look at trying to cut down on what time the latest you're going to eat, where you're eating. Are you eating snacks that are high in carbohydrates or high in sugar? Are you drinking stuff that's high in sugar? To modify that to something that you can maintain yourself for a lifetime.
Excellent, excellent.
Just,
Anyone else?
Sure. Just a few other tips and tricks in terms of weight loss, maintenance of weight loss, and just an approach. I remember about a decade ago, I lost about 40 to 50 pounds. And what I did as a practicing Muslim during the Muslim holy month of Ramadan, you wake up before the sun rises, you eat, you fast until the sun sets, you eat again. So I said, well, let me modify that. Since I can do that for 1 month out of the year, let me modify that, eat a minimal lunch, a substantial breakfast and dinner, and replace many of the beverages. As Dr. Sprott mentioned, we tend to drink really sugary laden beverages. So why don't I replace that with water? So one of the tricks in terms of managing beverages is you fill the cup largely with water and you add a colored drink, orange juice, apple juice, to give it color and flavor. And that way you're actually ingesting more water. Now, as you ingest more and more water, you'll excrete more. So you will run to the bathroom until your body gets used to that load of water. The other thing too is what I noticed when I lost weight was that I received a lot of compliments. And so, you know, we're wired for narcissism and we want to hear positive things about ourselves. And so when people would tell me how handsome I looked or how much better my clothes fit me after having lost the weight, that made the cheeseburger a little less attractive because no one ever complimented me on how many biscuits I ate, but they did compliment me after I lost the weight. So I make it a point when I observe that in others, I compliment them. Now you have to be careful with that because some people are really sensitive about weight. But I remember folks would say to me, man, something looks different about you. I can't put my finger on it. So to this day, I make it a point to comment on that observed weight loss in the hopes that it will help them sustain their motivation. Other tricks are, I work in a hospital that's a series of 2-story buildings. So whenever I go up and down, I catch the steps. So, right, and I refer to those things as instead of snacking on food, I'm snacking on exercise. So you could do that by running in place. You could do jumping jacks. You could, whenever you go shopping, if you drive somewhere that has a parking lot, you could park far away from the store, and then you're building in walking into your routine. And then reward yourself. So if you've achieved some weight loss, and really, you want to start with smaller goals, 3 pounds, 5 pounds, that kind of thing. Treat yourself. So, buy a new, when your clothes start fitting you differently, right? Upgrade your wardrobe, replace a thing or two, and it's a reminder of what you've achieved. Mm-hmm. Finally, weight management is like war. You have to really maintain vigilance. You have to constantly be aware of what you're putting into your body. So for example, working in a hospital, especially at nurses' stations, there's always food lying around. So when your feet left the bed and hit the floor that morning, those aren't calories you planned for, right? So oftentimes we're eating things we didn't plan to eat because they happen to be available. So imagine how many calories you eliminate if you eliminate those things that happen to be there. And because you didn't plan for them, you really didn't want them. So for example, let's say you enjoy ice cream as a dessert, but there's some donuts laying around at work, right? Why waste those dessert calories on donuts when you're an ice cream person? So again, just you have to be vigilant, constantly aware, and it's a battle. When you let your guard down, that's when the pounds pile up. Finally, we all deserve a little grace because COVID has really been a challenge to waistlines. So folks have been more sedentary, haven't been exercising as often, and they've been sitting around, during lockdowns with food, with alcohol, basically sitting in a jungle of calories, and that could certainly have health impacts. So constant vigilance and awareness, and being aware of little tricks and taking an inventory of what you planned on eating in the morning versus what happens to be in your presence.
Excellent, excellent.
Just, I'd like to touch on one thing that he talked about, which was fasting. And many people may have heard about something called intermittent fasting.
Intermittent, yes.
And there's certain variations of this intermittent fasting. Remember that if you fast, you stop eating for a certain amount of time. And remember, I talked about calories being stored. The carbohydrate storage of the sugar is stored in the liver. But if you don't take anything, a carbohydrate, to cause the additional storage of glycogen, or glucose or glycogen, which is sugar, then your body starts to break that down. So let's say you go to sleep at night at 8, almost a third of people by the time they wake up at 7 will have exhausted their glycogen stores, the sugar that's been stored out. And they will have started to break down fat. Now, the whole idea about this intermittent fasting is you only eat, if in the one that I think is, I say easiest to do, you only eat between certain hours. You eat between 10 and 5 or 10 and 6. And so if you limit your caloric intake to that period of time, after 6, by maybe midnight, you're starting to break down calories and you start to break down fat. Because once you no longer have glycogen to feed the brain, you start to break down fat. And so one of the things that you can do if you're going to try and break down fat is to consider, and I'd say talk to your doctor or go online and look at these various issues about the intermittent fasting, because they rely on the fact that you stop eating and then you're going to start to break down fat. The idea of doing it on a regular basis of maybe not eating for an entire day is a little bit difficult because you're going to go back and forth. Your body tends to adapt if you really start to fast on a regular basis. Your metabolism starts to slow down, so you don't burn calories at as fast a rate. So it becomes important for you to if you're going to look at some kind of management that looks at how you go about burning fat calories. The other one is the ketogenic diet that they talk about, or the Atkins diet, or these modifications where you're breaking down fat because you're not eating carbohydrates, and you're starting to break down fat because of the relationship between insulin, which is something that is responsible for diabetes, or in most cases. You look at those kind of things and talk to your physician about what kind of diet or what you might try, but think of something that you might be able to do for the rest of your life that keeps it in mind that in addition to what you're trying to do is you're trying to lose fat.
Yeah, correct. Dr. Garrison.
Woo! You know, when you look at medicine and you look at the cure for a disease entity, the fewer cures means we have a better handle on it. For instance, gout. There's 2 drugs for gout. That's it. When you look at weight loss, weight management, there are about 100,000 different ideas, which shows us that we really don't have a great handle on this thing. And it seems like every year or 2 years, there's a new thing. You know, Dr. Sprott mentioned intermittent fasting. That seems to be the new thing. Somebody asked a question about the keto diet. That was a thing. Then there was the Atkins diet, and then there was the grapefruit diet and the cabbage soup diet, and I'm just not going to eat on Monday diet. And there's all those types of things. South Beach diet. So clearly we don't have a good handle on it. One of the things that we do have a handle on is that every individual has what is called a set point. And your body, no matter who you are, is going to have a set point. And the body is so intricate and overlapping that no matter what we do to try to fool the body into losing weight, it's going to adapt and have a countermeasure to get back to that set point. For instance, if you're a long distance runner, before a race, what you do is you only eat protein so that you build up these enzymes that are going to increase the amount of fat storage and glycogen in your liver, so that when you're running, you can rely on that glycogen that's built up. You can give yourself an extra boost. Well, that is an adaptive mechanism. When the body fasts and you diet, your body is going to increase the enzymes that are going to store fat. Some people, their body is built such that they feel as if they're always starving. And some people, you know, I look at Omar Bey. Omar Bey, man, he doesn't ever look like he gains a pound in the 40 years that I've known him. Dr. Salam said that he gained a lot of weight and then he lost a lot of weight. Dr. Athlete has always been slim. He's always been the man, okay? You know, me, it's a constant battle. It's, you know, exercise and diet. But one thing that what he was talking about, there was a lot of minefields in there, man, that people have to navigate. And one of them, that minefield, was the positive affirmation for looking a certain body size, a body habitus. You know, the whole European body habitus, you know, that's, you know, African people, we ain't built like that. You know, what's the story? I like big butts. I mean, you know, we are built in a very, very different way. How many people in the world can get a 6-pack? It's 15% of the population get a 6-pack. They got the other 80% of us chasing after it. It doesn't happen. So you know, as Dr. Spratt was talking about, what we have to do, it has to be a program. It has to be a program for life. It has to be eliminate a little bit of this, have a little bit of that. Dr. Salam said, you got to have a treat day once in a while, you know. Vegetarians, you got to have protein in your diet somewhere. You got to add a little bit of fat in your diet. You know, you need all of these things. So it's not an easy solution. I don't think that this 1 hour conversation can solve anybody's weight loss or weight gain issues, but a constant follow up with your primary care doctor, get a nutritionist involved, and develop a plan that is healthy for you and that is going to help you get the losses and the gains that you're looking for over an extended period of time. Okay.
Excellent, excellent. You know, we've opened Pandora's box here, and I'm going to go, and I just want to go through just a few things, because what has been said so far is excellent. I mean, so many good points have been made by each and every one of you, and over the years I've developed the weight loss program because I had a lot of patients that had come to me or still come to me that are overweight and that have obstructive sleep apnea. And in the past, I was like, you know, if these patients could just lose weight, they would completely, you know, get rid of their obstructive sleep apnea. Most of them would. And so in trying to develop a weight loss program that would be appropriate for people of African descent it's challenging. We're challenging people, let me tell you. We love to eat, our food is great, and you know, I mean, it tastes so good. How can you not, you know what I mean, eat too much of it? So there are certain things that I understood that must happen. And number one is that we must understand that each of us have our own metabolic rate. And that we were talking about thyroid and that metabolic rate and how fast we burn calories, but each of us are different as far as that's concerned. One patient or one person may be able to eat 3 meals a day and have a normal weight, and another person eat 1 meal a day and store half of it as fat. We're all different, and understand that. And developing the program, basically the first thing I understood is that the person has to commit to wanting to lose weight and commit to any program that they start, they have to truly commit to it, number one. Number two, the program has to have, come about in a way that it's not punishing the person. I mean, there are a lot of programs that can be started out there, you know, the grapefruit diet and all of those, but who's going to stay on a grapefruit diet for the rest of their lives? It's just not going to happen. And what ultimately comes about is that you may lose 5 pounds or 10 pounds, and then when you stop that regimen that you couldn't tolerate anyway, you gain back 20 pounds. And in a year or two, you're heavier than when you started trying to lose weight. So that's a fail. So try in a way to develop something that the person is not being punished. And then the third thing is that understand that because we all have a different metabolic rate, it's going to be a lifelong change. Most likely it is. Your metabolic rate doesn't change because you got a little thinner or a little heavier. Your metabolic rate is your metabolic rate. So what we tried to do as far as the weight loss program is to make it simple. Number one, you look at your plate. Just whatever you like to eat, look at your plate. Simple. It's called the eat one half concept is because anything on your plate that's high calorie, cut it in half. Just automatically cut it in half. Anything so that would be your potatoes, your rice, your bread, your pasta, automatically just cut it in half. Half of the amount that you usually fix for yourself, just make it 1/2. Anything that's low calorie on your plate, increase by 1/2. And the concept is so, you know, to me, it's so simple. But you have to commit to it. Just like when Dr. Garrison said, you know, the concept even comes about with juices, half water, half juice. Everything is 1/2. If you're going to have dessert at night, you know you like a whole bowl, make it a half bowl. These are the type of things that can decrease your calories. And if you do that on every meal and think about it, if you had like a sandwich for lunch, make it an open face sandwich. Take the top slice of the bread off, and maybe have an apple and a little salad with the lunch. So it really does work. You don't have to change your cultural foods, what you love to eat, to be healthy and lose weight. You really don't. And as far as we call it a food break instead of fasting. What we say is don't eat your breakfast before 9 o'clock, and after 6 o'clock or after 7 o'clock at night, eat no more. And that way that you do burn those calories overnight, like Dr. Sprock and Dr. Garrison was saying. So there are concepts in the diet, and all I can say is that it's available on the app. And you just download the app to your phone, and please use the code 365 that you get the app for free. And I look forward to each and every one of you out there losing weight, being healthier, walking in the morning. Let's be healthy, especially after COVID. We need to be healthier as a people. Anyone else?
Omar, someone asked to
ask Dr. Kareem.
repeat the name of the app.
Hold on. Got two of you talking
app.
at once. Dr. Salam, you start off, and Dr. Sprock, you'll come second.
In the chat, it was mentioned, Omar, they need the name of the app. Someone asked for you to repeat the name of the app.
Oh, the app is OBHealthy. OBHealthy, you just go to your app store and understand the OBHealthy is the letter O, the letter B, and then healthy, HEALTHY, all one word. Go to your app store, download it to your phone, either Android or Apple, follow the instructions that you initially sign up, and then you have to become a member. Hit join and become the member, and please put in the code 365 when you come to the code, and you will not be charged. Okay, and look forward to everyone losing weight. Anything else, Dr. Salam?
Yeah, I just wanted to ask Dr. Salam a question. With the advent of Instagram and TikTok, a lot of adolescents are been concerned about what they see in their own body self-images. Could you comment on what the impact has been on the teenagers that you see relative to Instagram and TikTok?
Oh, Dr. Sprott, excellent question. Well, there's a lot of body shaming on social media. So a most recent example was thinking in terms of a celebrity before I get to the adolescent question. During the Super Bowl halftime show, I think a lot of people on social media commented on the appearance of the rapper 50 Cent and how he seemed to have gained weight. He's a pretty muscular guy, but like the young people say, he got into his feelings over that. So this is a very serious issue. I would encourage everyone to read the Surgeon General's advisory on children and adolescents' mental health, particularly in the setting of COVID. And so with the advent of social media and Instagram and TikTok, you have influencers, you have celebrities and influencers who are posting, who have vast resources to essentially create whatever kind of body they want with various enhancements. And so that is viewed as, the standard of beauty and something worth pursuing. And, average folk don't have those resources. They don't have armies of trainers and nutritionists and other things that could really enhance their body image. Another thing to look at is when you see a post, people, the smartest people and the cleverest people, they tend not to post the most unflattering aspects of their lives, right? So when you see someone, they've posted a photograph, they've posted the most perfect photograph, and perhaps what you're missing are the 15 takes prior to the one that was actually posted. So, the way the algorithms are designed in these social media platforms, they can really quickly, based on what you're clicking on, they can direct you towards weight loss websites. They can direct you towards the underbelly of weight loss in terms of eating disorders and things like that. And these have an influence on young people who have developing brains. They don't have the cognitive equipment and filters to really protect themselves and to protect their self-esteem from this onslaught of these perfect images. And it's been all over the media, Facebook in particular, and Instagram, and they're owned by the company Meta. They've really caught a lot of flack in terms of the impact this has had on young women, okay? And then with gender fluidity and this extensive menu of gender presentations, really no one is exempt, but it's wrought the most havoc on young people. It's contributed to suicidal thinking. It's contributed to parasuicidal acts, self-injurious behavior, like cutting and burning of the skin. It's caused unhealthy practices, young people, skipping meals to avoid weight gain, self-induced vomiting or purging after meals to avoid weight gain. So various forms of disordered eating. So social media is ubiquitous. It's something that it's not going away. We have to live with it, but it also has to be managed. And so I think the best way to approach these things is to have conversations with young people and try to engage them as they're engaging with these platforms. But body image is a central feature of controversy in these social media platforms that these young people are engaging with, like Instagram, like TikTok. And finally, the vivid imagery of the Instagram and the TikTok, it can draw these kids in, and it can mean much more to them than things that they read. So it involves sensory modalities like hearing and sight. And so it could be so attractive, and it could be, it could have an undue and imbalanced influence on young people.
Excellent. Let me just take this moment here to reintroduce the panel, number one, and number two, just to say a few things. Number one is that understand we're here every second Saturday at OBHealthy. Just sign on, and we just love for each and every one to be here and see us each month to take in the health knowledge, number one. Number two is that let me start with Dr. Atherley. Can we reintroduce the physicians for those who came in a little late? Dr. Atherley, can you introduce yourself, please?
Sure. Good afternoon, everyone. My name is Trevor Atherley. I'm an interventional cardiologist. My office is primarily out of Newark Bethesda Medical Center. Great to be here.
All righty. Dr. Salam, you're next.
My name is Dr. Kareem Salam. I'm a board-certified adult and child and adolescent psychiatrist on the faculty of Drexel University College of Medicine, and I practice out of a hospital in Northeast Philadelphia.
Thank you. Dr. Sprott, please.
Kendall Sprott, retired pediatrician. I specialize in general pediatrics and critical care pediatrics.
Thank you. Dr. Patrick Anderson. Patrick, you're still on mute. Can you?
Hi, everyone. I'm Dr. Anderson. I'm a GYN oncologist. I take care of women's reproductive cancers. I practice with many of these gentlemen on the panel, either through networking or at the Newark Bethesda Medical Center.
All right. Dr. Aluya, you're still on mute. Still on mute.
Yeah, Nelson Aluya, medicine pediatrics trained, assistant professor of medicine at Rutgers, New Jersey Medical School, and also an attending at Bethesda Medical Center. Always a pleasure to be here. Thank you.
Thank you. Dr. Jordan Garrison.
My name is Jordan Garrison. I'm a board-certified general vascular and bariatric surgeon, currently specializing in venous disorders, and I practice in Hackensack, New Jersey.
All righty. And Dr. James Court.
I practice in East Orange, New Jersey. My specialty is internal medicine, and I certainly enjoyed the conversation in reference to weight loss and exercise, but I'd just like to promote something that's dear to me. I always encourage my patients that they can walk every day, regardless of the weather, Once you have a space that's maybe 10 feet long, that's free of furniture, you can go back and forth for 1 hour or more. Thank you.
Excellent, excellent. The next thing I'd like to say is, and always I say this is the most important thing I can say during the whole webinar, please do not change any aspect of your medical care until you consult your physician, okay? And again, I'd like to thank OBHealthy for allowing us to bring this webinar to you. What I'd like to do next is, and I'd like to, Dr. Luya had sent me a memo this morning, and it was talking about preparing our patients and our people for, and family members for terminal illnesses and end of life. And, you know, we all kind of put this, I know for me, we all, I kind of put it in the back burner and not think about it too much, but it's going to occur to all of us, either to us personally or to one of our family members eventually. And it's so important that we're prepared, or that family members prepared, or we've gone through what exactly they want. And what I'm going to show you right now, it's called 5 Wishes. And this is a way that each patient,
Can't hear you, Omar, because you turned to the side.
Excuse me?
You turned to the side, we can't hear you.
Oh, I'm sorry. Can you see it now?
We can see it, but
well,
we can't hear you.
Oh, I'm sorry. Can't hear me. Okay. How are we down? Better?
Yes.
We can hear you, but we
It's
can't
called
see it.
5 Wishes. And basically, it's a pamphlet that each hospital has. And what it does is it actually very simply asks people what they would like to do at the end of life, or who would you like to answer for you. Let me read, there are actual 5 wishes, and let me read the 5 wishes to you. Okay, it says 5 wishes. My wish for, okay, the person I want to make care decisions for me when I can. Who is that person? And your family members should know who that person is. The kind of medical treatment I want or don't want. So there are many things that we as doctors can do. But it doesn't mean that that's what that person wanted us to do at the end of life. So it's important that they spell that out. How comfortable I want to be at the end of life. So are there medications that we can take pain away, or will a procedure increase the pain, or do I want to go through a particular procedure, or have a particular treatment or a machine put on me? That's a good question, and it should be answered. How I want people to treat me is very important. How do I want to be treated at the end of life? Or, you know what I mean? So important. What I want my loved ones to know, and this is very important, because as doctors, as nurses, as people who are caring for sick individuals, understand when family members come in, they're going to ask many, many questions. Do you want us to let that family member know those questions? Is there a key person to talk to? These are such important questions that we as doctors and nurses and healthcare professionals need to know from individuals that may come into the hospital or maybe at the near ending of life. Dr. Luya, you were the one that brought this up. Is there something that you'd like to say, you know, as far as this is concerned? I kind of laid out the basics, but give me some understanding of, you know, all of the physicians, of how you handle this, what your patients, how you talk to your patients about it, and how to go forward, and how should we go forward. Go ahead, Dr. Luya, please.
Well, thank you very much. Thank you for bringing up that paper you showed. Often enough, we tend to forget that these things are there, and you know, they're there for a particular reason. They often say we can't get out of this life alive, and one thing that's always permanent is death, and everybody will come on earth and we will die. And unfortunately, just as we live, there's a whole lot of discrepancy in healthcare delivery and system, and how people of color access health, the process of dying itself, there's a whole lot of discrepancies and disparity in it. And that's why it further goes on to compound the distrust that a lot of people who are people of color have when they experience their family members as they go through the process of death. And I think it's important that we begin to talk about things like this and have not just a bad view idea of what it is, but also come into the details and the nitty-gritty of how to assess this. Now, there's disease, there's health, and there's disease, and then there's the dying. Now, the disease I'm going to talk about in this case is in chronic medical disease. People with chronic medical problem, even mental, meaning dementia, end-stage dementia, Alzheimer's. It's a dying process as well. And people tend to forget that as that onset of Alzheimer's takes place, there's a common saying that, from the onset of Alzheimer's to the time of death, it's on average about 8 years. So it's a process itself. And family members need to understand that and begin to approach that system and get set for the end time. Tidying up, crossing out the T's and the dotting all the I's and everything else, and getting ready. Now, there's also what they call the chronic medical issues in heart disease. People whose heart end stage are failing to a point where they need, other augmentation and a process to getting transplant. People with chronic liver disease, people with chronic kidney disease, who are also on dialysis. These are chronic medical disease states that would usher in the inevitable. And of course, those who have cancer as well. So before you get to that point where, it comes to a point where those decisions are made, I think that every person needs to, sit down, and each and every one of us as well, sit down with our primary doctor and all the specialists that we have who care for us and discuss some of these issues. Be open. What are my long-term chances? What are the chances that in the next 5-10 years, I'll still be here? I'll still be alive? I've been asked those questions, and I'll be frank and open about it, and I discuss it with my patients as well. First, to mitigate the process of the disease itself, that's one. Two, to reduce the debilitating process of the disease, and as well as reduce the pain and suffering that come out of diseases. You can do that with medication. You can do that with, for those who have chronic lung disease, if they need oxygen, to get on oxygen, if they need all of these things are things we need to talk about. Now, from the paper you just read, I think every physician, everybody needs to have that as well. Maybe we all have to have those copies and share with our patients, especially those who are elderly, so that they be informed and then make informed decisions about, their end of life. Now, there are two things, and people tend to confuse both. There's a hospice and there's palliative care. Palliative care usually for those who have chronic medical disease and all the facilities or the opportunities or the resources that are available to help you manage those diseases. For instance, you need transportation if you can no longer drive, or if you need help with someone who comes to help you with, doing groceries, if you have dementia and there's nobody or family member to take care of you. If you get to a point where nobody can help you, take care of you, what's the next process of going to a nursing home and which nursing home you need to go into and how, best to approach care. Now, and all of those things, that come with them, the medications, multiple medications, all of those. And then we talk about hospice. Hospice usually for those who have less than 6 months to live. And people tend to see, and unfortunately, we as people of color or African descent, we don't like to talk about death in as much as we celebrate death that much. But In fact, a lot of people tend to say, oh, once you get a hospice, means they're just going to die or they're going to pull the plug. No, by the time you get to a point where hospice is a discussion, you need to have people who are qualified, who would, have that discussion, frank discussion with you. And you should have that discussion with your family member if you don't have the capacity to do that, in the presence, most likely with your physician. And those discussions should not necessarily be done in the hospital. Unfortunately, that's what's happening most of the time. And even if you have to have those discussions, and if you're in the hospital, you have a choice to have hospice at home or hospice in the hospital. And people tend to have, those processes where towards the end of life, they want to have closure. And the best and easiest way of doing that will help you heal as you lose that family member. And doctors have a profound role to play in that, because it's you they know. They don't know these other people. So if you help to soften the landing and introduce who the hospice people are and make them understand that they're here to help, I'll still be in the picture to help as much as possible, help to reduce pain, help to reduce suffering and all that. Then they'll trust the process and still continue the discussion and process. Thank you.
Thank you. Thank you. Anyone else want to chime in on this?
Hey, Omar.
Yes, sir.
Yes.
If I may add to what Nelson just said, it's the bigger picture, right? And it's an ongoing phenomenon, okay? And when you talk about health, you're not just talking about your physical health, but you're talking about every aspect of health, your financial health, the health of your family. And usually these processes is really to manage the patients and the circumstance, but to help the survivors, okay? And financial health is part of it, because if you want to talk about issues that break a family apart, let's deal with someone who dies and their financial health is not well, okay? So we talk about financial health and we talk about managing illnesses. And as Nelson says, chronic illnesses. And one of the things that fascinates me as a people is if someone gets a heart attack and a stroke, it's God's wish. But if you get cancer, it's a devastation of proportion we've never seen. Now, as Kevin noted this morning, we're dealing with a catastrophic event overnight of one of our dear colleagues. Okay, I think it's an ongoing process, and as physicians, primary care or subspecialists, it's important that when we see a patient, we don't wait for them to say, "Well, doc, how long does my loved one have?" As another question that was posed to me this morning. Some people feel that there's never a good time to have this conversation. My philosophy is it's always a good time to have this conversation. And there are processes which needs to be put in place. My own personal experiences, when I asked my mom, what does she want? She said, your big sister know what to do. Well, all my big sister knew what to do was dress to bury her in. But there are other aspects. And when young children are involved, it becomes even more important. So, as person who take care of acute illnesses, as Kevin know, we both operate on people where surgeries go south and then we have this issue of death facing us, or we both take care of a chronic illness, which is a cancer, which we kind of have some time to see how treatment develops, how responses are occurring, and to counsel families. You start this early, and what does it mean to get your business in order, right? You tell them, listen, I am not going to get involved in your finances, but if you have consultants that you can refer them to start doing some financial planning, because at the end of the day, even the tax implication of what happens to their finances is important. Do you do a linear transfer, a lateral transfer? What does all that means, right? But with respect to health, you have to manage symptoms, you have to manage expectation. And Dr. Salam will get in here and say, you have to help the survivors deal with what's going on from a mental health perspective, especially where children are involved. So yes, to that patient this morning who asked me, well, I know you're not God, but how long? Listen, have a family meeting. We're just starting the process. We don't want to tell her she has cancer because it's going to make her die quicker. No, I often say it's easier for someone to die than for us to allow them to die. All right. And most of these processes is to help the survivor. So start the conversation early on. Who is the proxy? Who's the primary decision maker in the event I cannot make a decision? When I'm unable to, what does it mean to be on life support? What are the interventions I would want and not want? With respect to my young children, you know, who's going to be the primary caretaker? You know, where do the finances go? What can I put in place to make sure that they enjoy the quality of life that we all work so hard for them to enjoy? So there's no better time to have that conversation than today. And you should employ every single specialty in medicine that comes in contact, from mental health, pulmonary health, renal health, you know, your cardiologist, everyone. Because when it comes to palliative care, which is the management of symptoms, each and every one has an influence. When it comes to hospice care, then each and every one has the ability to pull back and make this point guard, who is the end of life specialist, to come in and support the family, help manage the symptoms, and allow the process to take place in a kind, gentle manner.
Wait, before we go on, Dr. Kevin Clark came in. Kevin, can you introduce yourself and then we'll go on?
Sure, good afternoon. Sounds like I missed a lot. Sorry for being late. Dr. Kevin Clark, surgical oncologist at the Newark Beth Israel. I agree with everything that was said earlier. Very difficult discussions. I think very difficult issues to deal with. Without even knowing the specifics, I can tell you there's a lot. There's probably not one or two good ways of doing it, but there's a lot of bad ways of doing it. And I think that's reflected in a lot of the issues and complications that we see, especially in patients in the ICU and patients who are terminal. It's always, one of the things is when you deal with hospice and palliative care, it's somewhat of a continuum and a transition. And I think there are a lot of times where we don't offer services that should have been offered earlier, but it's a subtlety because, as Patrick will tell you, you have to give patients autonomy to come to that point where they don't want to be offered therapy and they've exhausted all of the potential resources for treatment. And I think in retrospect, you can always look back and say, well, you know, we should have stopped treatment earlier because it wasn't working. But one of the important things is if we don't think something's going to work, we're not going to give it. But you have to allow the patient to come to that point if they want to get treatment. And if there is a chance to allow them to come to that point. It's always a very hard decision. And it's, you know, we go back and forth and the retrospective scope is always much clearer, but it's, you know, at that point where you say, well, we should have stopped treatment 6 months ago or 3 months ago, or maybe you shouldn't have done that operation. Again, it's a very difficult judgment.
You know, Omar, this is a challenging topic, and there's so many different variations to this thing, but in essence, what's required is for people to make some decisions, especially as it relates to who they trust. Because Patrick touched on finances. You know, if something happens to an individual who is with it today, but they have a stroke and then they can't make decisions for themselves, someone who has to take responsibility, maybe you've become a power of attorney, which would be a legal document to deal with finances, sometimes a power of attorney to deal with medical decision-making, what an individual wants to do if they are incapacitated and there's no chance that they're going to get any better, what they want to do. If they are sick, do they want to be on a respirator? Do they want to have a feeding tube? And all of these points can be made in a document. And it's important that the document get created. It's important that someone knows where the document is in order to make it happen. Because if you have a document, but no one knows what the document says, then, you know, a lot of the things that you don't want might occur. People have, you know, might have cancer and they don't want to be resuscitated. Well, if no one knows that they have a do not resuscitate in place, then sometimes they'll get resuscitated. But the issue is that and very often we think about the next of kin being the person who becomes the decision maker. Maybe that's not the best person. And so individuals need to make a decision on their own as to who they want to entrust the carrying out of your wishes in terms of not just, you know, this end of life, but also what happens in terms of your finances and going forward. So, you know, there are a lot of documents that can be put into place that touch with all of these various aspects, including your last will and testament. You know, do you want to be buried? Do you want to be cremated? All of these things. And so, and very often these things are never discussed. And then when something catastrophic happens, no one knows what to do or what's best to do. And the person who might be put in the position of trying to make the decisions may not be the best decision maker. You know, I've gone through, you know, the whole issue of Alzheimer's. My mother-in-law lasted 15 years. I mean, and as she started to lose her ability to make decisions, we needed to step in and start to make decisions for her. If you have someone who has early Alzheimer's and they're single, they don't have anyone, you know, other than siblings, that's another issue as to when they're ready to turn over the control of their resources. They stop doing certain things that they normally would do, paying taxes and things like that. And there are lots of different things that you can observe that you need to step in, taking medications, all these other things, talking to physicians when the person who is responsible for them can't, you know, has diabetes. Well, you're taking your medicine? Yeah, I'm taking medicine. No, he's not taking his medicine. You know, lots of things need to come into place. And sometimes it's not difficult, especially when the person is really still with it enough to live alone, but not capable of doing all the things that they need to do.
Mm-hmm. Yeah, well said. Dr. Salam.
Just to jump in quickly, I have a few points to make. So from the mental health aspect of grief and loss, I'm going to recommend a book that I co-authored about a year ago entitled Bree's Journey to Joy, a story about childhood grief and depression. It's available on Amazon.
Who wrote that?
Global Health Psychiatry. I belong to a group of African-American psychiatrists. We formed a company where we talk to our community about mental health. So it's a beautifully illustrated book. We used a brother from Chicago with the children's story and then embedded as a parent guide and question and answer format. So I would encourage you, it's available on Amazon. So there's
I have my copy waiting to be autographed, by the way.
Wonderful. Thank you so much. I really wanted to say amen when Dr. Anderson spoke. One of my favorite expressions is the slogan of Nike, just do it, in terms of having the conversation. And if COVID has taught us nothing, it has taught us that a lot of people have died and we never got a chance to say goodbye. And so one of the most devastating losses of my life was someone who was essentially my age. And we had so much in common. And we were developing, our relationship was growing. And watching them go was like looking in the mirror. And what made it so painful was you even physicians, we can do this. You hope against hope, especially for these really, these people who mean so much to you, that something will happen. But as physicians, death is familiar to us. We know it. We know when it's coming. We have a pretty good idea when it's coming. And it's good to be honest. Why? Because when you're honest, you could actually initiate the process of saying goodbye. And that is critically important. And so with that one exception, all the other people who are close to me who I've lost, I've been able to say goodbye. And that means so much. And when they exit this realm, you're left with no regrets. Now, in order to say goodbye, you may need a medical opinion, someone who's caring for them, who has a pretty good idea that all resources and avenues have been exhausted and we're shifting towards palliation and comfort, okay? Now, let's shift towards the more mundane in the business aspects. Couple things. You don't want your financial plan for when you go to be a GoFundMe campaign. You don't want that. So you want to do some planning. And then in terms of actually doing something that you could actually do today, many of us have access to email. Think about what you want. Dr. Sprott mentioned, do you want to be buried, cremated, what have you? Who do you want involved in the process? Write an email. Write a lengthy email and include everything that you would want. And then what you need to do is the candidate, the person who you want to execute your wishes, you and them need to take a copy of that email and get it notarized. So what you have there is you have a document with some legal power that's a framework for, whether it be a will, whether it be a healthcare power of attorney and various proxies, but you have things written down and it's been witnessed and signed. That's a first step that we could all take today. And that way you could avoid a lot of chaos, because none of us, we're all leaving here, but none of us know when, okay? And finally, when you're dealing with children, with young children, many of us, I think many of us no longer have young children, but if you have young children in your family and there's someone who is transitioning out of this life and there's a pretty good chance they're gonna pass away, you have to have simple conversations in age-appropriate language. In the Bree book, Bree loses her Nana to COVID, okay? And you have to talk to them. Nana's not well, she's struggling, she's having problems breathing, she's in discomfort. And depending on the relationship the youngster had with Nana, they could regress and they could revert to earlier stages of development, especially with young children, thumb sucking, bedwetting, tantrums and the like. But it's best to rally around young people, have these conversations and give them an opportunity to interact with Nana, give her a hug and a kiss. What young kids struggle with the most in terms of death is the permanence of it. So typically they can master that at around age 10, but earlier than that, it's very difficult for them to understand the fact that once Nana goes, they'll never see her again in the flesh. So, but again, it's super important to do something now. And that's something you could do, just document your wishes and get that notarized, even if you don't have an army of professionals to help you with the financial planning, the legal aspects. And of course, you want an informed medical opinion in terms of the prognosis.
Let me just affirm the words of wisdom from Dr. Salam. I'm most impressed, of course, impressed with all of you, but certainly under these circumstances with the importance of planning and communication. Now, my field, as you know, as a cardiologist, is one in which is often touched by the finality of death. And this is either in actuality in terms of my patients or in implications and expectations, because when people hear about serious heart disease, the next thing they think of is dying. So I think that communication with the patients is extremely important. My patients either may be chronic and facing the impending ultimate, or unfortunately, many of my patients coming with heart attacks or other acute circumstances in which they themselves or their families may recognize as leading to death in a shorter rather than a longer period of time. So I certainly agree with the concept that communication is paramount. Communication with the patient, communication with the families. And I certainly like to give advice where I think my advice is appropriate. I will bow to the fact that I cannot give the economic advice and some of the other advice that might be required for patients and their families at such time, but I can try to steer them in the correct direction to receive such. But above all, communication, appropriate discussions with patients and with the patient's family.
You know, I so appreciate the discussions that we're having here. I think these discussions between all of the physicians is just as important as us telling our patients that their blood pressure should be in a certain range. Giving our opinions, letting people know that we're human too, and that we're having the same thoughts and discussions with our families that they're having, and trying to give some direction. What I'd like to do next is,
Omar, one comment.
Yes. Who's this?
Dr. Court.
Oh, yes, Dr. Court, go ahead, and then I'll go on.
Yes, I wouldn't be too long. One of the problems that I face in terms of the patients is they don't understand use of the respirator at the end of life.
They
Quite
don't,
often,
they don't understand what, Dr.
whether
Court, I didn't
or
hear
not
you.
they should be placed on a respirator based on what their condition is.
Mhm.
Usually when they sign on their living will sheet, they said no respirator. But in many cases, as you know, the respirator might just be something temporary to take them through a crisis. But if they say no respirator, our hands are tied. So we have to be careful that they understand when a respirator could save your life and prolong your life, or when it will be of no benefit.
Mhm.
So my one comment.
Yeah, respirator, let me just go through real quick as far as ventilator or respirator. It's a machine that will breathe for you when you are not able to breathe for yourself. And basically it requires intubation. Intubation is when we have to put a flexible tube through the mouth into the airway. And that allows the machine to administer breaths to you so that you can, your lungs will get the air and your body will get oxygen. And fortunately, most patients that we put on a ventilator come off the ventilator. And from a respiratory or from a lung standpoint, they do well. And it can be for many reasons that we'll have to put someone on a ventilator. It could be for severe COPD or emphysema. It could be for an exacerbation of that. It could be for pneumonias, viral infections, many reasons we may have to put someone on a ventilator. It's very important for the physician when talking about the ventilator that we give the family as well as the patient, if the patient is not in extremis at that time, an understanding that the machine is there to help. Most likely it's going to be short term. There are those situations though that when we put someone on a machine like that, a ventilator, that it's difficult to get them off and get them off that machine. And usually the physician will have a basic understanding at that time that there may be a chance that the patient may have difficulty coming off the machine, and that should be explained as well. So I agree with Dr. Court. There in our community, a lot of times we don't understand that it may be temporary, but these discussions should occur with the family or with the patient at that particular time. And hopefully it's not in a situation where it's an emergency and the machine has to be put on emergently.
One other comment on, because when I train and when you train, when a patient is on a respirator, we have to go to court in order to take them off. But now, once family agrees, we can always take them off.
Yeah, yeah. But yeah, that you're talking about a terminal extubation. That's what you're talking about, or end of life extubation. And yes, that can occur with appropriate consulting with the family, meetings with the family, and agreements. The family agreeing and understanding that the prognosis is terminal, and that no matter what we do at this particular point, the the endpoint will not change. And that's true.
Yeah, Omar, I think that's very, very important that you stated that. You don't take someone off the respirator that has the potential to recover. It's when everything has been exhausted and it's deemed that the continued use of the respirator is futile, that it won't improve and it won't get better. But outside of that, you have someone who is having a respirator for support, and their lungs or whatever their underlying condition is not at that point terminal. You can't take them off respirator.
Right. You know what I would like to do at this particular point, and Omicron, I mean, COVID has affected all, I think it's affected all of us. It's affected our families. It's affected everyone, I think, in the country and throughout the world. And I thought of this last night, and I said, it would be so unique if we as physicians just state how COVID has affected us, either personally, our practice, or how we think, or how we move forward, or what we've done in the past. How has COVID affected us over these last 2 years? And I'll start off with this. And you only have to chime in if you feel, that you have something that you really want to put forth. I'm not going to say this is mandatory, but I think it's important that the people that out there that listen to us understand that, so many things go through our mind as physicians trying to treat them and keep our families well and safe. And it would be nice for them to be able to connect with us that way. I'm a critical care doc. At ICU during COVID was traumatic. It was traumatic for the nurses, traumatic for the medical student residents, and traumatic for the attending physicians. There were so many, unfortunately, there were so many people dying so quickly. And we unfortunately did not have good treatment for it or truly understand this disease. I think back on it now, and I think, over the years of practicing critical care, so many years, it's something that you understand that when someone expires and you have to make that phone call, that phone call is something that no family member wants to receive. I don't care at what point or if they think they're prepared for it. But during COVID, there was a special situation because no family members could visit. They couldn't come in and have that connection or have that time to, to let it all out and to have that closure. So it was a special time, and there was so many patients dying and so many family members having this problem. And as a physician, that is the last, put it this way, as a family member, that's the last thing that you want is to receive that phone call. But on the other side of that, as a physician, that's the last phone call, or well, that is the one phone call, I should say, that you never want to make. It's probably the hardest thing that you're going to do as a doc, is to tell a family that a loved one is gone. So, it's just something that I felt that, and thinking about putting stuff together for this program, this webinar last night, that I thought I should share, that it's difficult for both sides, and closure is difficult for both sides. Anyone else? How does Omicron affect you as far as?
Omar, I wasn't frontline taking care of patients when COVID hit, but it reminded me of when I was doing critical care with HIV in kids, where the diagnosis was a death sentence. And there was a lot of fear about the spread and everything else. And we learned that, it didn't spread by respiratory, but COVID did, which made me extremely frightened about how many folks could die so quickly because it was spread via the respiratory tract. And I was, responsible for a hospital with developmental disabled, which were particularly vulnerable. But I also was angry about some of the lies, I can say the lies or the misrepresentations about COVID and how to prevent its spread. The issues of this is just no worse than the flu, when it was horribly worse than the flu. And people says, well, you don't need to wear a mask. And, people didn't quite understand the issue of, the wearing of the mask is preventing you from getting infected, but also preventing others. And the distorted news that came about that didn't have anything to do with science made me angry about the unnecessary number of individuals that end up dying because people didn't trust the science or the doctors, or and so it made me very angry about that, and we've had many discussions about trying to tell the truth about what it is. And then finally, when the vaccine was developed, all the drama and trauma about not getting the vaccine and everything else, and to me, this issue of vaccines, and we've had anti-vaccine things that occur before, but this was something that not getting vaccines, especially for our people, again, caused an unnecessary number of deaths. And to me, I don't know what the future holds, but I suspect that I hope that COVID, in terms of me, was a once in a lifetime thing, especially with the respiratory issue. AIDS was horrible, but this was even worse. I think that the issue of going forward is the sad state of our world in terms of the mis and disinformation that comes about. People, have no problems in having their kids get immunizations for measles, mumps, rubella, all these things that when I was a resident, kids died. And now all of these things have been eliminated through vaccines. And this is just another vaccine that was designed to prevent people from dying. And there still is misinformation going on about it. So.
Right. Yeah, Dr. Court.
As one of the victims, I remember what I went through. It really wasn't easy. And I wish I would never have to encounter conditions like COVID. So far, I've lost 34 patients. One of the worst experiences that I've had is to lose 2 of my patients, a husband and wife. They're gone. I wouldn't see them again. Fortunately for now, we have treatment, and one wonders, had those people have contracted the virus right now, they probably would be alive. Unfortunately, they're gone. And thank God we have treatment, and we all have to continue to encourage our patients, please be vaccinated. I had my first vaccine the second day when it was available. Of course, you're going to have side effects and complications and minor complications, but it's the best thing that we have right now. You could see the difference. Look how many deaths there were in 2020 compared to what there is now. Please, we don't want to go through this again.
Hey, Omar, if I might say something. The experience with COVID highlights why we need professionals like all of us to take care of us when we're ill. Professionals like Dr. Salam to help with the mental health aspect of it. Because all of you guys on this panel have known that in the last 3 years, I've encountered some personal stuff that I would be lying if I say I don't have some mental health things. And it's through the colleagueship that helped me get through it. And I've often said, I am shocked that I didn't get COVID. I am shocked Dr. Clark didn't get COVID because of the nature of what we do day in, day out, COVID or otherwise. It never got in the way of us taking care of patients. And it's almost like waking up and figuring out who's in the foxhole today, helping us dealing with the shelling and the bombing. For me personally, it has brought all of us closer. During the pandemic, I find myself calling my colleagues, "Are you okay? Can I go to bed tonight?" When my friend and my adopted dad, Dr. Court, he said he was a personal victim, I was about to lose my mind. It was that simple. When we lose colleagues that we thought were going to survive, none of us knew what to think. I think for me personally, the impact on COVID, it makes all of us, all my colleagues, become more and more special to me. The one statement that's now just like ingrained in my daily conversation, get out there and be safe. Just be safe. Because, you know, even today, 2 years later, I'm still hearing people citing religious reasons why they shouldn't be vaccinated, citing the concept of personal choice, why they shouldn't be vaccinated, completely overlooking the cost, not just financial costs, but the human factor that it takes and the toll that it took on all of us to take care of them. And not just them, people who got sick, and they themselves, should they become sick. The conversation often just morphs into some irrational conversation that becomes really disturbing and continues to perpetuate some of the emotional components that I continue to face today.
I hear you. Jordan, yes, Dr. Garrison.
You know, I've never been one to mince words, but you know, over the last 30, 40 years, there's been this gradual erosion of the confidence in doctors. And a lot of that is with the increase of paraprofessionals, physician extenders, and things like that, in which I've looked at it as sort of a backdoor way into becoming a practitioner. And the insurance companies always encouraging these things to save costs. And so people now go on Facebook, they go on Ask Your Doctor or whatever website they go, and they get information that has no context to it. And so therefore they believe that they know as much as the physicians without knowing the intricacies and the play that one thing may have on another thing, et cetera, et cetera. They may know one fact, whereas in order to adequately address something, you need to know 10 facts. And it basically has shown the selfishness of the American population, and that I want what I want when I want it. And the whole thing about, you know, wearing a mask impinges upon my personal freedom, or my kid is not being able to socialize because they have a mask, or whatever the wild bullshit is that these people have said. And I think it was just said that they don't look at the impact it can have on another person. They just look at the impact. You know, freedom ain't free. And we have lost, and there's been a general erosion of our morality and the way that we deal with each other in this United States. There has been the formality of meetings. People show up dressed in t-shirts in any old way to formal occasions and things like that. We have lost our civility, and the humanity that we exhibit to one another has just been eroded by the, you know, I can do what I want, and I should be able to be a free spirit. And we've lost the civics which teaches us how to treat one another within a free society. And at the loss of, you know, way people think doctors are rich. People think that doctors have no problems in the world. They're rich, they're riding around Mercedes and things like that. But I have a practice in which it is totally outpatient, totally elective. And when COVID came, we had to shut our doors. We had to shut our doors for 8 months. I have 9 employees with families. And where was the money coming to take care of those families? The money, you know? So yes, it needed to be shut down for a while, but the extended time that it was shut down because of the selfishness, the misinformation that was given out there, these families were hurt. You know, I had kids in college and tuitions needed to be paid. Life went on. So it was difficult. It was very difficult on me. It was very difficult on these 9 families that were depending upon what we had to do. So some of them are still recovering from it. Some of them have had tremendous losses, that not just the personal loss, I'm talking about the financial losses that they've had, that it's going to be difficult for them to recover from. And I just think the selfishness, I've had had arguments. Well, I've stopped arguing with family members. I just tell them they're stupid when they start spouting off information like, I want to have children and my testosterone level may go down. I won't be able to have children if I get vaccinated. Just idiotic things. So I just think we've come full circle with this not trusting physicians. All of a sudden that the paraprofessional is the person that can give the best advice. I think we were very special in what we do, and we work very, very hard at attaining this level of expertise. And it's not something that can be, there's no shortcuts to it. But for somehow our society thinks that there are shortcuts and other people can do what we can do. And it's tragic. The level of care is going to go down, and it continues to erode and erode and erode. So yeah, I'm a little pissed. Just my words may show that.
Well, George, Dr. Garrison, I'm glad that you never mince words, and I respect you for that. And number one, and I think that's a gift. And to be I'm really serious about that. It's a gift to be able to state what you believe, because a lot of us hold it in and not say. And when you state what you believe and you think it out and logically, and you're speaking logically, it's important. Dr. Salam.
Yes, let me first jump in the boat with Doctors Garrison and Sprott in their anger. And I know there have been moments of rage that I've had, especially when it came to family. Because you hope that you have a history with family where you've never betrayed them, and you want so desperately for them to trust you. So, but like I think it was Dr. Garrison who mentioned, at some point I said, folks are going to do what they do, and COVID justice, it could be swift and it could be deadly. And I have to reach a point where we can't have this debate that it won't resolve. So that's where I am right now. And you always hope and pray for the best for your family and your loved ones. So that was deeply disappointing. But it further heightened my belief that we are among the best ambassadors in terms of health for our people. Our people will, I'll take liberties, but they may give us the benefit of the doubt. And that's a responsibility, and that we should use that wisely. And I think we have. So it's put us in a position to advocate on a really big stage, using this platform and other platforms to get the word out to our people, because we are our people and they are us. And I'm going to take further liberties that as Black men who with medical training, I assure you, nothing was given to any of these doctors on this panel except maybe an opportunity. But beyond that, nothing was given. And medical training is hard. It's not easy. It involves tremendous sacrifice. And, I would just, I would ask our people, have we ever betrayed you? And if we haven't, why would we start now? So I love that we're in a position to advocate and really do our part to help get the word out in the service of keeping our people alive, right? So history has shown us, if we don't have us, no one will have us. So we must have us. So to echo what Dr. Anderson said, we're privileged to have a community, a fraternity, a village of Black physicians to lean on and to share these struggles with. So these powerfully negative feelings and emotions, they have to be metabolized through communication. So you can't walk around with these negative emotions, negative thoughts and feelings pent up. They will destroy you. So it's important to have this village where we can have these conversations. So I have it among psychiatrists and I have it here, and I'll say it. I'm going to claim it. It's very important that you look like me because you understand, and there's less of a learning curve. There's less explaining and educating I have to do. You understand. So I think professionally, we're helping each other live and extend our careers, and personally, we're extending each other's lives with these bonds we have and helping us metabolize these powerful experiences.
Excellent, excellent. All righty, if no one else has anything else to say, we're going to end it here. I just so appreciate all of the knowledge that I should say knowledge, wisdom, and understanding that you bestowed to each of us on this panel, as well as everyone attending the webinar. So thank you very much for all of your knowledge and the fact that you come on and be a part of this. What I'd like to do is I'd like to thank OBHealthy for allowing us to present the webinar each month. Every second Saturday, please tell family and friends to attend. It's all about educating, health education for the African American community. Please do not change any aspect of your medical care until you consult your physician. No matter what we say, it's so important that you follow your physician's advice. Until next time, I'm just going to say peace and thank you very much for each and every one of you again. All righty, look forward to each and every one joining us second Saturday of next month. And we will be here, and trust me, you will be here as well. Thank you. Peace.